So there'll be a Q&A at the end of each talk. And I'll be taking questions both from online and in person. But yeah,
Great.
go for it.
Thank you and good morning, everybody.
Can everybody online hear us all right? Great.
Super. Thank you very much for inviting me to speak today. So I'm a palliative medicine trainee and I'm just starting my PhD looking at how we share prognostic information with patients who've got heart failure. So this is really new territory for me, speaking in kind of maybe a philosophical space. So hopefully what I can impart today is useful. So I'm going to be speaking on the potentials and pitfalls of prognostication and answering the question, what is dying? And thinking a little bit about what empirical research evidence we have to support us. So as a first speaker, I thought I'd set the scene, just showing the title of this paper. It's from 10 years ago now. It's called Concepts and Definitions for Actively Dying, End of Life, Terminally Ill, Terminal Care and Transitions of Care. And these are all terms that we use clinically and in our everyday practice. But what this paper, I think, is showing us is that, yes, there's an element of wanting us to soften our language around dying, but actually, I think a lot of these come about because we don't have conceptual clarity around what dying is. And the results of this paper will be of no surprise, that actually none of these terms are well understood or well defined, and that this lack of shared understanding does cause us problems clinically, and then in terms of the research that we're trying to do to underpin our clinical work. And I don't think we've made much progress in the last 10 years. The other thing that struck me about this title was that the term actively dying, we don't use the opposite. We don't have a term passively dying, but the use of the word actively suggests that there is something dynamic and changeable around the nature of dying and whether we can actually capture that within any conceptual definitions we try and think of today. So what am I going to cover? We're just going to have a brief outline of what prognostication is, why it's important. I'll then spend a little bit more time looking at the methods that we use to prognosticate and what we know from the research about the accuracy of those methods, and then what it means if we're going to use prognosis as a means of defining dying, and what we need to be wary of if we do take that approach. Okay. So what is prognostication? In its very broad sense, it's just making any prediction about the future. And we should be doing that all the time. What is the expected disease pattern with somebody with this condition? What are the chances that this treatment is going to be successful or not? And I guess specific for today, when is this patient likely to die? And before the era of successful and effective treatments for many of the conditions we see, the central tenets of medicine were diagnosis and prognosis. You called upon a doctor to get the diagnosis and for them to tell you what would likely happen. Over 10% of textbooks had information and teachings on prognostication. But now, when we've got biomedical models, curative models as the dominating approach to health and illness, a lot of this has disappeared. It's not really in our textbooks and it's not really in our curriculum. So actually, clinicians feel poorly trained to do this type of work. And with the fall of paternalistic medicine, we're now also having to navigate articulating that uncertainty to our patients, as well as supporting them to make decisions in that uncertain space. So I think we all have an inherent understanding or realization that there is value in predicting when death will occur. Practically, it helps with our clinical decision making. There are benefits in terms of personal planning, whether that's emotional, practical, financial. And it also helps to find service access. So specifically with regards to time, there are certain government benefits that you can get the highest rate of if you have an expected prognosis of less than 12 months. Or it could be to do with your expected changing needs that are going to change dramatically over the next few weeks and months that get you access to funding for care, whether that's at home or in a nursing home. It also really underpins a lot of what we consider good medical practice. So you really do need to know what your prognosis is and what's likely to happen to you to provide informed consent for whatever treatment you may or may not be offered. You also need it to participate fully in shared decision making. There's also something on an individual level that being given a prognosis or being told, and when you're told, really defines the level of control, opportunity, and choice you end up having for decisions that you have to make, whether you have any of those or if it's too late. So I'll move on to how we prognosticate. And I thought I'd first look at what we have in terms of clinical guidelines. So the GMC and NICE have two documents where they use the term end of life. And these are for people approaching the end of life, and they consider those the people who are likely to die in the next 12 months. NICE sort of suggests that you should use certain tools, and I'll speak to those in a couple of slides' time, to routinely identify these people. We have a big jump. The next kind of guidance we have is this care for dying adults in the last days of life, and they say that's the last 2 to 3 days of life. And here they use the word dying. And they have a list of signs and symptoms, for example, noisy respiratory secretions that may indicate that somebody's in this phase. So something happens between these two documents where dying supposedly starts. So can these theoretical graphs of different disease trajectories help us answer that question? Now, I know for clinicians, these figures will be very familiar, but for those who maybe haven't seen these before, I'll just speak briefly to each of them. They plot somebody's health or function against time. So then this first one in A is a picture of sudden death. So you're at full health or full function until something catastrophic happens, and then essentially instantaneously you drop off, your function declines, and when that line hits the bottom horizontal line of time, that's death. So then we move on to B, which is termed terminal illness. And the classic example here would be a diagnosis like cancer, where you remain fairly well for a period of time, and then at a certain point, you start deteriorating at a fairly constant rate. Your diagnosis can come at any point along this line. C is a picture of organ failure, so either heart failure, chronic respiratory disease, for example, where you have these acute episodes where you become less well, but there is a potential for recovery. Maybe not to the same level that you were, but there is that chance. And D is a picture of frailty. The example that everybody uses here would be something like Alzheimer's dementia, where you need a lot of support and care for a long period of time. And the deterioration is slow, and it may not even be perceivable day to day, week to week, or month to month. So these are all theoretical pictures. They are kind of widely accepted, I guess, clinically and in the academic literature. And there have been some attempts to sort of match whether this is what happens in real life with empirical evidence. But I think what's important today is thinking, okay, how is this going to add to our thinking around dying? Is it something to do with a functional level, that anything above the line is considered not dying, anything considered below is dying? You could see that would mean for some people that they go in and out of dying in the organ failure group, or that you may have a very long period of dying in the frailty group. Or is it something more to do with the rate of change? Again, does this come multiple times in your disease picture? Is it hard to see? Or is it something to do with a bit of both? So looking at the literature on how we actually do prognosticate, there's 5 main ways. So in reality, I think day to day, a lot of us rely on this clinician prediction that relies heavily on intuition, clinical experience. And there are multiple ways that we formulate it, and it's classified into these 3 groups. So if somebody were to say, I think somebody will survive 3 days, 18 days, 7 weeks, that's considered a continuous prediction. If we start using broader themes like days, weeks, months, that would be categorical. And probabilistic are ones where we put a percentage at a certain time. So I think there's a 60% chance that you'll survive till Christmas. The next one would be the surprise question. So the original surprise question is, would I be surprised if this patient died within the next year? And there's variations now of that question. Some people replace died with survived. Would I be surprised if somebody survived? And you can also change the time frame. The next one here I've called indicator lists, and these are the ones that the NICE guidance say we should use to be routinely identifying people approaching the end of life. And so there are some acronyms here. SPICT is the Supportive and Palliative Care Indicator Tools, and the GSF is the Gold Standards Framework. And essentially these are a list of situations that patients may find themselves in that might indicate that their time is now limited. So general indicators are multiple unplanned hospital admissions, and more specific things may be the need for long-term oxygen therapy. And actually the surprise question and indicator list were never really devised to be prognostic tools per se. So they're actually broad and they capture a lot of people. And yes, they capture lots of people with life-limiting illness, but whether we would consider all these people to be dying, I think that's definitely up for debate. The next thing would be performance scales. So these are lists where, as a clinician, you have to measure or match the patient you see in front of you to a description that's on this scale. So for example, the ECOG, you'd get a score of 3 if you could only care for yourself in a limited way, and you were bound to your bed or chair, you weren't mobile for more than 50% of the day. You then move to a 4 if you were dependent on others for all of your self-care, or you're completely bed and chair bound. And some of the other scores, like the Prognostification Performance Score, the KPS, have more domains that you have to match across. So for example, how conscious and alert somebody is, or whether they're taking food and fluid. And again, the performance scales were not formed to be prognostic, but they've been shown to match with the length of survival and correlate quite closely across lots of different settings and lots of different disease groups. And in fact, actually, when there have been studies that looked at clinician predictions and tried to really find out what that intuition is based on, there's a study by White that used something called judgment analysis. They used a number of different factors, all clinical markers, say, for example, urine output, level of agitation, performance scale. And they found that actually performance scales are the things that clinicians are using most to come to their intuitive judgments about somebody's prognosis. And then the last one are the tools and algorithms. So these are, I guess, formula in the background that you type in different parameters and it chucks out an answer for you. So the PPI, the Palliative Performance Index, categorizes people into likely to survive less than 3 weeks, 3 to 6 weeks, or above 6 weeks. The PIPS, the Prognosis in Palliative Care Study, works out a probability of somebody surviving to 14 days and 56 days, and based on that information, categorizes them into days, months, days, weeks, or months. So it's slightly more opaque. You don't really know what's happening in the background, and the tool you pick really depends on what kind of answer you're looking for and what time frames you're looking for. So how accurate are all these methods? I think the first thing to say is that there's a real problem defining accuracy. It's not agreed in the academic literature, and I think it's complicated even further by not really knowing in clinical practice what kind of inaccuracy is meaningful for people. How, would a difference of 5 days make a difference, mean something for a clinician making a decision? Is it a big deal for somebody who's actually dying if there's a 5-day inaccuracy? And the reason I use a 5-day example is, I'll give an example. I've been asked to predict when patient A is going to die, and I say, I think it's going to be 18 days. And we're always told never to do that, to put a number with a time frame. But for the purposes of, say, a study, that's what I've been asked to do. A lot of them would say that I was inaccurate if I was out by 30%. So I would only be correct if they actually died between day 12 and day 24. So if they died on day 11, I would be wrong. Similarly, we think, okay, well, we're telling people to use these broad categories. So if I was in this PIPS study and I said 18 days, that's classified as weeks. anything between 14 days, so 2 and 8 weeks is weeks. But if they die on day 11, that would be classified as days. So again, I'd be incorrect. But in reality, you'll all have a sense yourselves, would that be meaningful to you if a 5-day difference? So interpreting, I guess, all of the evidence that we have, that's the big caveat. What we do know is that we've got fairly consistent evidence that clinician predictions do correlate with actual survival. So luckily, it's good for us to know that we do recognize deterioration. We do see when people are getting less well, and our guesses are better than chance. So we should hopefully still be with a job. The thing is that we do have a tendency to overestimate, to predict that somebody's going to live longer than they actually do. So we're optimists. Because we've been seen as not being perfect, that we are going to be inaccurate some of the time, are the tools any better than us? And actually, no method has been found to be superior than clinician predictions. And within that space, if you're developing a tool or trying to suggest that you should be using something else, you should be comparing it to how well a clinician's actually performing. I think the furthest anybody's got to really advise that we use tools is in the recent European guidelines. And again, it's in very specific circumstances that you might choose to use a tool over yourself, but maybe it would be just an adjunct or to triangulate what you think. The funny thing is that we're actually quite inconsistent with that application. This is just being human. But there are a small number of studies that look at our certainty and how consistent we are. So I can be 90% sure that somebody's going to die within the next 72 hours, but I'm still actually going to be wrong 25% of the time. I can be 70% sure, and I'm only wrong maybe 30% of the time. So that increase in certainty doesn't seem to change how accurate we are. The other thing that they found is when they asked people to give a probability of somebody dying within the next 12 months, and then whether they would be surprised, that surprise question, we were actually very inconsistent with our own threshold. So when we estimate between 33% and 50%, sometimes we say, I would be surprised that someone died. And with the same percentage, we sometimes say, I wouldn't be surprised that somebody died. So if we're going to be using the surprise question as a threshold, for example, to say, okay, am I going to refer this person for the higher rate benefits, or am I going to sign off that form? Sometimes we say yes, and sometimes we say no to exactly the same type of patient. So that's something for us to be aware of. And I think that last point really exemplifies that we really struggle to operationalize the process of prognostication in practice. So if we are going to use prognosis to answer the question, what is dying? What does that mean we think dying is? So looking at the ways that we seem to be forming prognosis, it seems to be a biological process or an accumulation of events that we are looking out for. It's something that we can observe or measure. And we seem to have a threshold that tips us one way or another, albeit it's a very opaque one. And if we are taking this view, what are the problems? So as I've sort of alluded to, there is inherent uncertainty with all of this. And I've already explored that we have a real difficulty then translating this uncertainty into practice. There's also this problem with constantly moving goalposts. There's so many things that influence person's prognosis that it can be constantly changing. So are we keeping it under review all the time? And because it's something that seems to be observed and measured from somebody outside the patient, the power really sits with the clinician. And sometimes it's not even, it might be specifically that they want a doctor to say, or sometimes we even defer to the specialist of the disease. So nobody's wanting to make a prognosis until we've got the expert in the room. And I guess lastly, there's a focus on time that we're inextricably linking it to the event of death itself. We're not thinking about the needs or the experience of any individual. Everything is very external to the person with this approach. And I'm really interested to hear the other talks today, because actually writing this talk has made me reflect on, I guess, what I do every day, bread and butter, and really think very differently about how I think approach prognosis. So thank you.
Thank you very much. More time for questions. Okay, so for the people online, if you have a question, figure out how to look at the chat. We will try and alternate questions in person and online. So for the online people, if you either write your question in the chat or just write question, and then I will unmute you and you can speak. So, questions. Who has questions?
Wait for the mic.
You.
Thank you very much, Dr. Shu, for your presentation. I am Jerry from China, and I'm currently learning MSc program of healthcare in Institute institutes. So my question for you is that when you're working in a team, where different people have different view of prognostication, does it happen, and when it happens, what do you do?
So we would always, I guess that's it, where we work, we're always in multidisciplinary teams and actually get a lot from working with others. And there is some evidence that suggests that actually putting your heads together and discussing somebody's prognosis may make you more accurate as a group than just as an individual. So yes, I definitely think that there's always benefits to be working in a team. I guess how that happens and how you come to consensus and who has the power in those discussions is not as clear. There was a PhD student in UCL who has done work on this, and they've recorded conversations in MDT meetings where people try and discuss prognosis. So look out for her work. Her name's Andrea Brun.
Jenny?
Yeah, thank you very much. I'm just wondering how you factor both into your prognostication. I mean, it seems a lot of what you're saying is about trying to give as much, get as much information to be accurate and consistent and in a very changing world. And I work in IT, and one of the things I've sort of come around to more recently is that extinguishing hope is a big problem as well, or another aspect of it. And I just wondering if you factor that into what you.
I mean, when it comes specifically to prognostication, I think that's where the research kind of really falls down, because it's something that you can't measure, but yet every clinician in the room would recognize that a patient's hope or the patient's mental well-being or the patient's outlook really can make a difference to their outcome. I guess in reality, that's the difficulty of all of these conversations, isn't it? It's balancing that hope with giving honest information. How we do that is really difficult. And of course, there are lots of frameworks and things that suggest how you should communicate well and how can you read the other person and how much information that they want. So there's lots of things out there. There's the 4 W's plus 1, that's I wish, I wonder, kind of framework from St. Luke's. But yes, I think when you try and translate it into academic work, I don't know how hope is sort of measured, and that's the pitfall, I think, for a lot of this.
For others, looking at the way you have revenue customer, it might be PhD because I'm very on source. So if I have PhD at the time, the facility would be quite a population. And one of the things I thought on the graphs was the two things which, so I wrote a very similar graph with our real time.
the algorithm and all you've got is like 2. And I guess there's sort of that two one is that in those trajectories, what's missing from all these things is the trial engagement. You know, in those different things, and your belief about the reversibility of the trial engagement. So, like, if someone's having a major hemorrhage, if they're in the middle of a field, they're done. If they're in the middle of the resource, they're not done, because you've got all sorts of they're going to spiral. So it's just remembering that it's a process of reversibility, and so that these things are absolutes. They're actually about what process. I think the second thing about what is receiving
Thank you.
Thanks, Christina. That's excellent thought. I was wondering about when you think of prognostic tools, and a lot of the way of interpreting those is through this sort of. Thank you. So this, in terms of interpreting the prognostic tool, there's a lot of things to realize, performance skills, and the lens of interpreting this is very physiological. That's a marker of frailty of physical muscle stuff. But I wonder actually whether there is scope within clinical practice for looking at those from a sociological perspective. So a marker of a loss of function being a loss of their ability to themselves, their life and their role. And actually it's a proxy for the wider continuum what diet might be for that person. And others from there, almost asking the surprise question there, would you be surprised if you lost this in the next one? And yeah, it was just more a thought to see what your thoughts are.
I think you're right. I was looking very much from the academic literature standpoint rather than in clinical work. And I think we do all of that, don't we, in our clinical work anyway. We recognise that there's a lot of loss and meaning for people. And then it translates and boils down into this tool or this list. But I think when we're related to people and having those conversations, we're doing that work. And how do we, I guess, in a forum like today, bring all of that into something that we can discuss together?
I was struck by the slides and said, one of the big problems that we are focused is time. And of course, prognostication is where you went down. How can we frame that problem into? Have you thought about it? Or maybe someone else in the audience say, how can we change the focus from the when to a different question? Do you have any reflections?
I would say that I think I was very much with you. My brain really struggled to think about, okay, well, if it's not this, what is it? And actually through doing this work and kind of thinking how to present it, my mind started to shift. Like, actually, there's lots of things that this isn't capturing. And that's why I'm so interested to be here today and hear from everyone else. I don't think the answer is going to come from me. But it's definitely something that I, through preparing, have gone, you know what, there's something missing actually in the way that I've approached this before.
I have read an article. It mentioned that maybe for some informal caregivers, for example, champions for plastic assistants, they have kind of both those relationship with the patient, and they sort of they can access they have changes in functionality or other continuous in their life. So maybe they have a more average alternatives in life services. So my question is what's their roles in your clinical practice in the area of prognostication and personality work?
So I think the question is that there's lots of people who care for patient healthcare workers, maybe even like
maybe even more accurate.
Yes.
Yeah, to some extent.
So I think you're completely right. We don't want to overlook that there are lots of people who have been with a patient very close, caring for them, who may also have their own sense of what's going on. In terms of literature, you know, there's nothing consistent to say that one group of professionals, for example, are better at prognosticating than others, although to be fair, that most of the time it is limited to doctors and nurses and maybe not healthcare assistants. You know, you wouldn't be surprised if working in a hospice, you know, the people, volunteers, or the people who prepare and deliver the meals, all of these people will have interactions with patients on a regular basis and have a sense themselves of what's going on and when things may be changing. How we actually incorporate all of those people into our decision making or into our discussions in real life, I think we just have to be very mindful that the MDT doesn't necessarily finish with the people who are in the room, and that there are lots of sources of, you know, information or opinions that can come from outside that. I think in palliative medicine we're probably better than maybe some other groups that don't work so closely in MDTs, but there's always stuff to be learned and for us to be reminded of. So I think that's a great point. Like, who else is there within this team that could help? Or even, as I said, talking to the patient themselves, the carers, what are their thoughts?
Thank you very much. It's really interesting. So it's thank you. So throughout the whole presentation, I was thinking quite a bit about service in the UK news recently around clinician assisted dying. And the whole time it's been, you know, how we begin to talk about motivating but also what this benefits. But it then made me think a bit more about, is there any research or anything that we can look at from that side of the fence around it? We've already got patients, population of people who themselves are saying that they want to actively initiate the process of themselves life. How do we also reflect on that?
No, it's a great thought, and maybe I'll just look at Arnie and say you'll need to put on another day looking at that side of things and inviting a different speaker.
Yeah, we did kind of try and avoid the assisted dying question because it is so different and so loaded. But yeah, maybe watch the space.
Thank you very much. So I'm going to share on them. Maybe it's this project. This seems to be a struck one of the we are going to talk about without being more accurate to conditions to bring the same patient better. I think it's a lot because of the sort of patient that pathways is different, and their personality and their support system sort of feeds into their ability to survive or their will to survive, and also the fact that we as clinicians also can develop a relationship with some of our patients over a long time, and sometimes that affects the sort of prognosis we want to give them. They are also burdened, we are also with them, and that also affects your judgments. And I think that those are some of the things that are the sort of subjective things that we don't often consider.
No, I agree, and you know, it's just very human that our judgments like that can be. And I'm not saying that's an incorrect thing, that we need to become robots and more, automated. But I think it's just interesting, if we're using that kind of measure to determine if somebody's going to access a service or not, then, how are we doing that and why are we doing that? And is that right?
So it is sometimes considered tacky for the chair to ask a question, but I'm going to do it. So you mentioned something about inconsistencies between the kind of degree of belief that a clinician might have that someone is going to die and the probabilities that they also think of them dying. And I did a bit of philosophy of probability, so this is very triggering for me.
No, I'm you.
But so at least within mainstream philosophy of probability, even if that exists, there's a kind of standard assumption that the rational thing for any person to do is to calibrate their degree of belief to the probability of the event. So if you think that someone has a 50% chance of dying, then you should have a 50% degree of belief in them dying. So if there's an inconsistency, one interpretation might be that clinicians are being irrational, which is entirely possible. But a more generous and charitable interpretation might be that actually that's not the only way people decide whether someone's dying, right? So the surprise question is potentially taking into account multiple concepts of dying. And so, for example, if a clinician thinks that there is some reversibility there, even if you have a very high risk of dying, your uncertainty about whether it's reversible will also play into that. And so there are these kind of multiple sources of uncertainty, which might change your degree of belief, because your probability of death is not necessarily the only. Risk has also triggered by this question. Is not necessarily the only thing, right? So part of charitable interpretation might be that the reason that there is inconsistency is because there are internal conflicts in whether or not you think conceptually someone is dying.
And I guess that kind of answers a few of the points that came from the audience as well, that I guess we're not looking for exactly a linear relationship when we're saying everybody has to be consistent. But I guess it's if we are going to be using certain means to act in a certain way, I guess we have to be aware of what's going on underneath it, that there may be inconsistencies and potentially why. Sometimes the questions aren't clear. So I'll try and.
So yeah, I think there's a lot of reverb because of this room with the microphones, that people just hold the mic away from them. It's not as wobbly. But if there are no further questions, then thank you very much.
Thank you.
That was great, very intense. Thanks.